COVID-19 pandemic has crossed the one-year mark. Cases, hospitalizations, and deaths continue to trend downward. But even with that progress, we cannot let our guard down. Using data to inform the response to the COVID-19 pandemic can help improve COVID-19 testing and vaccinations, in turn reducing illnesses, hospitalizations, and deaths. COVID Data Tracker is CDC's easy-to-use home for COVID-19 data. It offers easy-to-interpret visualizations, such as interactive maps and graphs of vaccinations, cases, hospitalizations, and more. Grouping data by category makes it easier to find the data you need. CDC is helping people across the country get vaccinated while tracking the progress of the national vaccination program and sharing that data publicly. There has been significant progress in vaccination. While COVID-19 vaccinations are increasing across the country, Black, Hispanic, Latino, Asian, and tribal communities are currently getting COVID-19 vaccines at lower rates than white communities. By using data to drive vaccine implementation and the response to the COVID-19 pandemic, cases, hospitalizations, and deaths could continue to trend downward.
Well, welcome. Welcome to our session on using data to inform effective risk communications. This town hall discussion is going to focus on some of the ways that we use data, and we're going to define data probably fairly broadly, ranging from survey to community engagement to focus groups, in-depth interviews. We're going to discuss some of the ways that data has been used and insights have been used to inform COVID-19 communications and how they can be used to inform COVID-19 vaccine-related communications. There are 4 panelists who are with me this afternoon or this morning, depending where you are. First of all, my name is Glenn Nowak. I'm a professor at the University of Georgia, and I'm also the director of the University of Georgia's Grady College Center for Health and Risk Communications. I spent 14 years at the Centers for Disease Control and Prevention before returning to the University of Georgia about 8 years ago. I spent 6 years as Director of Communications for the National Immunization Program and 6 years as Director of Media Relations for CDC. And in the last 7 years, I've been doing quite a bit of research on vaccine hesitancy and acceptance. I'm joined today by Annie Amjad, an MD and Commissioner and State Health Officer for the West Virginia Department of Health and Human Resources, by Robert Jennings, who's the Executive Director of the National Public Health Information Coalition, by Bob Rauner, MD and MPH, who's President of Partnership for a Healthy Lincoln, and Stefan Wallace, who's Director of External Relations for the COVID Prevention Network. We are going to talk about our experiences, share some of the advice and guidance that we think will be helpful to people when it comes to COVID-19 vaccine and vaccination acceptance. I think we'll start with a poll question. And the poll question that we're going to start with is, what is the main reason you decided to attend this practitioner town hall session? Option 1, I want to hear about best practices related to effective COVID-19 vaccine communications. Option 2, I want to increase my understanding of the need to tailor communications to specific populations or communities. Third option is, I'd like to learn new strategies to engage community members and leaders. Number 4, the moderator and panelists represent diverse perspectives that will be informative. And number 5, the topic relates more to my job than other concurrent town hall sessions. So if you'll just take a minute and cast your votes for one of those 5 options, that will also help us as we make our remarks and structure this session. All right. So the number one reason is I want to hear about best practices related to effective COVID-19 vaccine communications. Followed by, I want to increase my understanding of the need to tailor communications for specific populations or communities. And I'd like to learn new strategies to engage community members and leaders. And so we will focus on trying to address those interests as we proceed today. So we're going to start. I'm going to turn to each of the panelists, and I'm going to ask them a question and have them speak to that question. And then we will also be addressing questions that you pose through the Q&A. So I'll start with Stephen. What are some of the successes and lessons learned related to community engagement and partnerships that you've found that they're helpful to develop public education materials and activities, particularly that would mitigate barriers to vaccine uptake?
Thanks for that question, Glenn. And it's Stefan. The lessons learned really have been taken from a lot of our work with other disease areas. So I represent the COVID-19 Prevention Network. And, we basically leveraged a lot of the examples, the strategies that we've taken, again, that we've used in HIV and other areas. And some of those strategies include really centering the community as part of the response. What better way to engage communities through communications, through, outreach strategies than to engage the communities and find out directly from them, what do those strategies need to look like? How best those strategies need to be packaged. So some of those strategies for us have included developing a strategic plan that was completely informed by our community relations work. And this plan included the development of the expert panels. These expert panels were population focused, and they were comprised of members who are experts and scientists in working in communities, but they were also members of those communities. An example is the African American and Black expert panel that is comprised of Black scientists and experts, but across disciplines, social and behavioral science, medical ethics, and clinical care. We also have a national faith initiative that has done amazing work. And this was another strategy that's been leveraged from our other areas. And really engaging the faith communities to help bridge the conversation between faith and science. Also developing a community working group. And, we've also had quite a bit done regarding marketing and advertising, communicating the science of vaccines, communicating how mRNA vaccines are created, communicating what does it mean to be a participant in a clinical trial, while also supporting our clinical research sites with materials, education, information and tools and resources that support their efforts on the ground. So we have, a few different tiers of work that's happening, the work that's happening through the clinical trial sites to engage communities and potential participants and participants directly. And then, of course, the work that happens out of our operations center to engage larger communities, stakeholder groups and partners. And some of these partners, groups that we've had relationships with for decades, and some of them are new partners that we've developed relationships in response to COVID-19. And then finally, I will just sort of mention that a lot of this has really revolved, as I mentioned, around the reality that centering communities is really, really, really critical in developing any strategies to engage those communities. So I'll pause there.
Thank you. And in your work in West Virginia, I understand you've partnered with a lot of different entities, including a local university, to conduct community focus groups. Could you tell us how that partnership and other partnerships have informed your communication strategies around vaccination?
Sure, Glenn, and thanks for having me on. Let me start with the university. So yes, we've had a lot of partnerships with multiple stakeholders in West Virginia. West Virginia University is one of our main universities in Morgantown. They have a Media Innovation Center, which focuses on public communications, and they have great people up there working that have worked on focus groups. They started in December to help with our vaccine rollout. So they have a team up there that started out with some baseline surveys to work on focus groups to see what we need to do to help identify, the beliefs, the concerns, the worries that people have with the vaccines that are coming out. And with that in mind, for example, they identified early on that the term mass clinics don't bode well with at least people in West Virginia. So early on, we knew the term mass clinics weren't going to do well with our population. So we started using the word community vaccination clinics. That's one example. Right now, they're also assisting us with surveying or doing focus groups with our minority populations. They also did a few small focus groups with our Department of Corrections. They're also assisting us with some healthcare workers. We also have partnerships with our faith-based organizations. Our leadership team had a webinar last week with multiple, I think we had maybe over 30 faith-based leaders on there about how we can tailor vaccination efforts, for the long-term efforts, getting into the spring and summertime, how to address maybe some younger people who are vaccine hesitant, so to speak. We also have surveys out to the long-term care facilities. On the first go around, we had a lot of people who wanted the vaccines. And then the second or third time around, we had this hesitancy. So we have a lot of stakeholders or partnerships with multiple entities that help us get this type of information, because information is only as good as it is unless you use it for something. So any information we get back, we take it back to our groups, and then we try to find out what it is that people are worried about. And then we get that back to those other interest groups that can deliver that information, because it's those trusted groups that are going to be able to speak to their own groups internally and get that information to them safely.
And a very good example of one of the most important reasons to do community engagement, to do research, is to find out what words resonate and what words don't resonate. We often, among ourselves as professionals, use words like mass clinic, mass vaccination clinic, without giving it much thought. And without realizing that may, as you point out, not actually resonate really well or very effectively with the people that we're trying to get to come out to those clinics to get vaccinated. Even vaccine hesitancy, a lot of times that term is used in many different ways. And it may just be that we have to address people's reluctance. They are actually open to getting vaccinated if we can persuade them. So they're not refusing, they're just reluctant. I'm going to turn to Bob. Bob, how are you collecting information on population-specific vaccine hesitancy to help increase vaccination rates among racial and ethnic minority populations? And how are you using data to inform your strategies for education, outreach, and reducing barriers?
Oh, well, we're looking for other sources of data. I mean, most everybody can find census tract data, for example, or Census Bureau type. One of our best sources recently was one of our Medicaid managed care plans, because they track they have data on their patients of influenza vaccination rates, so we know how likely they are to get vaccinated, but they can break it down on race, ethnicity, and language preference. And so you can do a lot of good subgroups because it's a very huge sample size. And so, for example, we got to learn Lincoln is a challenge because I say it's the diversity within our diversity. We've had so many successive waves of refugees that all those populations act and think differently. And so, for example, our Black population, you've got about half of them are sort of historical descendants of slaves, and some of their hesitancy goes back to things like the Tuskegee experiments, whereas the other half are recent Sudanese immigrants. And those are very different cultural populations in how they act, think, how they do things. And then we kind of did some focus groups. We have some community breastfeeding educators and community health workers that serve both populations, say what is the reasons for the resistance. In one group, it's the legacy of the Tuskegee experiments. And so they want everybody else to get experiment on first, so to speak, kind of thing. Whereas the Sudanese is what I might call more of like the agrarian fatalism. And it was kind of a funny incident because one of the folks was talking about, an elder in the mosque and why he didn't want it. And it was more that it's my time. And a couple of us started laughing because I grew up in Western Nebraska in a farming community, and said, he sounds just like my grandpa, actually. And so, sometimes those funny things there's things that make us different, but also funny things that unite us sometimes. The other thing we found out that, there's some subgroups in the Medicaid population, that's a low income population. Our lowest groups weren't just the Black, it was actually the white Medicaid population is very low vaccination rate. On the flip side, our Hispanics and Asians were much higher. And then Hispanic, when you subgrouped native English speaking versus non-native, we found out the more recent immigrants were more likely to get vaccinated. And so until you start looking at that granularity data, you don't know where your bright spots are, where your challenges are going to be. And I think that's really helped us target. And then we pulled some other sources. So for example, our public school system releases a statistical manual. So you can look at the ethnic breakdown of every elementary school in Lincoln. So you can look at 39 elementary schools, and they're roughly reflective of their neighborhoods. And it's more granular than a census tract or a zip code, for example. And the other thing we're working, like Ain said, we're working with some surveys. So our College of Public Health did a statewide survey, but that was most of the respondents were white. We're going to do some oversampling of our minority populations here in Lincoln, so we can kind of figure out, what are some of their reasons for what are their barriers? Why might they not want to get a vaccine? And so the more we learn that, the better. And the other thing we're moving toward now is trying to figure out, it's not just the message, but the messenger. And who should the messenger be? And sometimes it should be somebody from the community and sometimes not from the community, actually. And so we may try to have even some panel discussions, like for the African-American population, more Black, we may have someone who's a leader from, say, the church, but also a primary care doctor who's also Black, and then maybe the non-person like me, the white guy. And so somebody having a perspective from different folks, you may help answer various questions. I found out from one of a doctor who's Guatemalan that he says, actually, yes, they want to hear it from me, but they also do want to hear it from a white guy too. And so if both of us go, it's sort of a push-pull, inside out. And so we're trying to figure out, what are the right messages and who are the right messengers sometimes. And sometimes it's a combination approach.
Thank you. Robert, I'm going to turn to you. Many people have already spoken about some of the strategies and best practices for effectively communicating with the public. With your broad expertise in public health communications, particularly with the media, what are other insights that you would like to share to most effectively use data to develop a communication strategy or to shape and guide messaging?
Well, first of all, thank you for allowing me to be a part of this distinguished panel and give me a reason to put on a tie for the first time in quite a while. It's really nice. Well, in many ways, the role of the public health communicator has become more complex and nuanced. And it's never been an easy profession by no means, but no longer do we just, look at the press releases or the, being active on social media or being the spokesperson or answering media calls. We've kind of evolved over time. The discipline has, especially over this last year. So now we're looking at roles as researchers, roles as statisticians, and as policymakers. We used to be at the back of the room saying, hey, don't forget communications when you're planning your initiatives and when you're doing the outreach to communities. But now communicators are being pulled to the front of the table for their expertise. And so there's always been this, this art and science elements of communication, the art being those catchy taglines, the jingles that resonate. In fact, I came up with one, don't throw away my shot, which for you Hamilton people who like Hamilton, you know where I'm going with that, but that wasn't picked up. So, we'll see. But, but that's the art. But then there's the science, which, you've talked about already. And that is where we actually take the application of our knowledge and understanding of the natural and social world based on evidence. And I would suggest that the science portion of what we do in communications now is at the forefront. And what does all that mean as far as data goes? It means we must embrace the use of data and the information that we gather to hone our messages for greater effectiveness. We need to seek up-to-date real-time data through focus groups, polls, surveys, community assessments, and other ways of gathering information. And we need to be able to interpret and understand the data and not just look at what would be a good tagline or soundbite, but really dig deeper into the information to see where the challenges are, but more importantly, where the opportunities are. And for example, if you look at any poll from around the country right now, it says that 70% of Americans are eager and anxious to get vaccinated. Well, if you dig deeper into that data, that may not be so. You may be around 35, 40% of Americans who are really accepting of the vaccine. So you have to look deeper. What are the hesitancies in that data? What hesitancies can be found in that data? And how can we use that data to do more targeted messaging and outreach. And so we're going to talk a lot about data during this session, so I'm not going to get too deep into that right now, but I would like to invite those attending this session to, there should be a link in the chat box, and there it is. And it is a Ask the Experts communication webinar series that it's a partnership between the Association of State and Territorial Health Officials and my organization, the National Public Health Information Coalition. And it's entitled Making Sense of COVID-19 Polling Results. So I encourage everybody to take a look at that. And then finally, we have to be able to frame the messages from the information that we've learned from all the data that we've gathered. And then that allows us to jump back to the art of what we do, and that is having the right message for the right audience at the right time. And Glenn, if you'll indulge me at one point, I know we're gonna talk a lot about trust during this time, and trust is at the core of everything that we're talking about. So I'd like for us to reimagine the acronym TRUST in the risk communication principles, with the first T being timing. We're always taught that, you got to be first and you got to be accurate and all that, but you're not always going to be first. So you really do need to have a good reputation and have big and solid relationships if you're not first, that can give you the edge. The R could be used for the right message at the right time for the right person. The U could be understanding, which involves more than just empathy. It's understanding the beliefs and the sensitivities and the concerns, and being respectful of those beliefs and sensitivities. And the S, selfless service. There's no shortage of selfless service in public health right now. We've all kind of committed ourselves to responding to the COVID-19. But it requires us to go a little further, endure a little longer, and look a little closer so we can help support individuals and communities in need. And finally, the last T is take action, so that people can take action, so that it gives them something to restore some sense of control. So thank you.
Terrific, thank you. One of the biggest, I think we've talked about data. The question I'd like to pose to the panelists is, how do you define data, and what data do you find or have you found to be most helpful when it comes to developing communications plans or formulating messages that are more rather than less effective? So it's a two-part question. What kind of data have you found to be helpful? And I guess I can start. Bob, you want to start with that question?
Yeah, I mean, I guess combinations of objective and subjective, and don't have preconceived notions about what's going to help you out. And so, by getting the Medicaid data to say, okay, that gives us some numbers to start. Now let's go actually start talking to people, because until you hear their stories, sometimes you don't know the rest of the story. Like, Robert was saying, there's more to it than that. And then also sometimes knowing what's going to resonate. A lot of us are probably data people. So numbers and spreadsheets speak to us, but they don't speak to the general public as much. So as many numbers as I want to throw out to people, because I'm so analytical, it's not what the general public wants to hear sometimes. And so they're going to have to hear some stories. Sometimes what motivates people, I get excited about data, but most people don't, but they might hear things like, I'm doing this to protect my family. That's more motivating to them. And so just trying to figure that out. And I think getting, they say mixed methods, objective, subjective, using combinations of it, and so don't hang your hat on one thing, keep looking for other things. And then look for your bright spots, so we obviously seeing there's some ethnicities that are doing really well. Is there something we can learn? And of course, learning from our peers, all of us are looking to our peers in West Virginia and say, how do we copy your vaccination rates? So the more we learn from each other, the better.
So Anne, I'll ask you, what kind of data do you find most helpful? And what's your definition of data?
So it's pretty much what Bob said too. We have quantitative, qualitative data, but I find qualitative data more useful. The focus groups that ask more questions and that sit down with people and ask what word choices are more useful. We get quantitative data too. Percentages help us a lot. One of our biggest questions with long-term care facility data, for example, were what percentage of your staff have have or have not been vaccinated. We wanted to know that right away. And numbers are important, but that doesn't tell us the why. Why do people not want to get vaccinated? So anecdotal information is helpful. Betty told me this, or her sister told me that, but those things do matter. What people are saying, what they're reading on social media, where do you get your information from? So I think that type of information is important, that type of data, whether it's through focus groups, through 8 people or 80 people. When you put that information together, you get the sense of what a county might be thinking, or what demographic or what population might be thinking. So I think that type of qualitative information or qualitative data, I think, is important, especially when you get into long-term planning for COVID vaccination. The flu vaccine has been around for a while. We pretty much know why people do or do not want it. But I think with Operation Warp Speed and how fast it came out, we need a lot more qualitative data moving forward for the COVID-19 vaccination.
Thank you. Stefan?
Yeah, I want to echo everything that's been said before, and also to add that I think it does intersect with trust. As Robert mentioned before, and thinking about who the persons are that are trustworthy in communities to provide information to get the data that you actually need, right? So that's part of it. Also thinking about how we've been able to distill down the 84 or 87 page FDA documents into more accessible documents to really help translate, the science and the findings from the studies. This is something we've done for the Moderna study as well as the Pfizer study, and we will do it for the others as well, of course. And so I think all the data is helpful, the anecdotal data, the community level data, and the feedback that we receive about, what are the critical questions that communities are asking and that they're talking about. And those questions have changed. The questions that people are asking now are very different from the questions, communities were asking 10 months ago, 8 months ago, 6 months ago. So being responsive and thinking about how can you best position yourself to get this information? Do you have the trusted relationships to acquire the data, right? And then what do you do after you get it? Because that's a part of it as well.
Robert?
Well, I'm the only one on this panel without doctor in front of his name, so I am going to be more of just grassroots. When you talk to people and you tell them that 80% of people are eager to get vaccinated, for example, that means nothing to them. And so it really does get back to the trust. So the data that I like to use in the work that I do is geomapping, where you find out where the most needs are, and then you go into those communities and talk directly to those, to the folks in those communities. And you get to the table. I heard a term yesterday. You go to the tables that are already set. So you're not trying to create new relationships in the middle of a crisis. You kind of go in where the table is already set. And so my point is that data means a lot to preparing, especially in messaging for the communicator. But when you really get down to it and you dig deeper, it doesn't really explain everything that you know. So you have to be able to listen and to be able to understand. And I'm going to go back. You said, what is the definition of data? I'm going to say any information that you can get that can help you make an informed decision.
Good definition. So the next question I'm going to ask you, I'm going to first ask the audience, and it is, which of the following has been your biggest challenge with regard to using data for effective risk communications? So which of the following has been your biggest challenge in gathering data for effective risk communications? So it's actually a two-part question. So first one is, which of the following has been your biggest challenge in gathering data for effective risk communications? And the options are insufficient resources, lack of expertise, not enough time, or appropriate partnerships aren't already established. And then the second question is, which of the following has been your biggest challenge in using data? So When it comes to data, you have to gather it. And for sometimes that is the most difficult thing. There's also challenges with respect to using it. So the options in terms of what are your biggest challenges in using data are having the capacity and or expertise to tailor messaging to all the populations of focus, developing partnerships and communities to enhance data collection and use, understanding how to use data and information to develop communications plans and messages, understanding how to proceed when there are issues with mistrust, and the final option is collecting feedback on communication activities to evaluate and adjust as needed. So those are the two questions we'd like you to take a minute to respond to, and then we will have each of the panelists talk about challenges with respect to gathering data as well as using data. So in terms of the first question, which of the following has been your biggest challenge? Two things, or challenge to gathering data for effective risk communications is not enough time and insufficient resources, followed by appropriate partnerships aren't already established and lack of expertise. So those are the ones we'll talk about shortly with the panelists. And then when it comes to using that data, the biggest challenges include understanding how to proceed when there are issues with mistrust. So data oftentimes tells us that there are issues of mistrust. It's helpful and important to know that, but yeah, it can be very difficult to then figure out how do you address those issues? How do you effectively overcome them? Another challenge is having capacity and or expertise to tailor messaging to all the populations of focus. We know that messaging and communication strategies are often most effective when you can tailor them to specific audiences or segments, but it also becomes more challenging the more audiences and segments that you have. A third challenge is collecting feedback on communications activities to evaluate and adjust as needed. Often that encompasses being able to have real-time or near real-time feedback. And then others too that are still significant are understanding how to use the data and information to develop your communication plans and messages, along with developing partnerships and communities to enhance data collection and use. I think it probably makes most sense to kind of take those two questions separately. So I will ask the panelists to first talk about challenges when it comes to gathering data. You've heard from the folks who are attending this about their challenges and where they lie. What have been some of your challenges, and more importantly, what advice would you offer to address or overcome those challenges? Robert, I'll start with you.
Well, I'd say all of the above is true. And I will say there is definitely not enough time. That's going to be the number one answer every time you pose that question. But then you have to ask yourself, you really do need to take the time, but do it in a smart way. And that is go to the places that already have the data, because trying to collect the data yourself is time consuming, and you might not be able to do that. But there are probably within your own organizations, Medicaid data, as Dr. Ronner pointed out. You can get Medicaid data, you can get polls, you can get surveys, evaluations, community assessments. Data exists, you just have to know where to go to get it. And then the other piece of that would be how to use that and how to incorporate it in your communications plans. And that's when I said that being a communicator, our jobs has become much more nuanced and much more sophisticated and complex now. I think when you dig deep into the data, you can find the answers to a lot of those secret questions. You can start seeing where the hesitancies lie, And again, we keep going back to trust, and it probably is trust, but what is not being trusted? Is it institutions, government, medical professionals? Who do you not trust? And then who do you trust? And then, as been mentioned, we need to go to those trusted sources in order to be able to carry our message. But this is very complex, and I'll be interested to hear what the other panelists have to say regarding this.
Thank you. Bob, your thoughts?
Yeah, I'd say, I think I think it was Robert who said, the table that's already been set, use that table. And so I think one of our biggest problems is sometimes people just want to keep reinventing the wheel when it's already out there. You just got to know where it is. We can find existing data sets that point us in the right direction. Then we move on to the focus groups and the surveys to get a little bit better understanding of the why. What is the resistance there? I think, I think we've got a great, not unfortunately a bad history of why, like the Tuskegee experiments, makes a lot of sense for why there's that resistance there. I actually don't know what the resistance is in the low-income white population is. I guess we got to figure that one out. And so we're going to have tailored messages, and the hesitancy may have different sources in different populations. That's where I think the work's got to be done next, is what's the resistance in the subpopulations, and what are the messages that may or may not fix that hesitancy.
Brian, your thoughts on the challenges involved in data gathering?
Oh, my turn?
Stefan.
Oh, okay. Go ahead, Stefan.
Sure. I think that equity and power sharing are constant challenges that I hear in the field often. And when I think about this, I guess what comes to mind for me is how are groups, organizations, coalitions meaningfully engaging communities as part of the process. And sometimes you find yourself, like with COVID-19, we're in the middle of a pandemic and many people are sort of trying to build the ship and board it at the same time. But doing the work to build that foundation and framework now can actually support future efforts. And so I think it's part of an investment strategy, right? How do you do the work now to invest and provide returns, not just now, but also later? And some of this can look like a task force or a community board that can be created to inform what this looks like. But again, part of it's how do you engage the people to join the board, the task force, but also being mindful that, bi-directional relationships are critical. So it's not just going out and tapping community members to come and inform your process, but what are you investing back into the community that you're pulling from?
Good points. Anne?
To add to what everyone else is saying, and not to, repeat the challenges that we faced in West Virginia, which is the same, which everyone else has stated. I think bringing other people in your community to the table to add to that, so that you're not reinventing the wheel and having to reproduce data, is helpful. Whether it's other community partners, other stakeholders, other people who know their communities better and are able to listen and communicate effectively, also builds that trust. Because you can have all the data in the world, and if you're not utilizing it and making it effective in a timely manner, we know that it is useless in a way, I guess. So we know, for example, as we stated earlier, word choices matter, and it's effective to communicate effectively in any relationship you have, whether it's a doctor-patient relationship, personal relationship even. So I think that makes a difference. So any data we collect, we need to turn that around and make it effective, especially in communication. Teamwork is effective. Partnering up, even with churches is effective. We know that. So getting information quickly and getting it out there effectively and with the right words makes a big difference. I know here in a rural area such as West Virginia, having vaccines on hand immediately is important, and it's not that you're convincing someone to take a vaccine, but having that availability on hand, on demand, is important as well. So, these types of things, if it's a struggle to get out there and get the vaccine, how much of it is a struggle for them or someone to come back out and get it if you don't even have it available? So, these types of logistics are important, I think, when someone is already on the fence about it or uncertain about it. So these types of things, I think, should be thought out well as you're moving forward with something as new as COVID-19 vaccines.
Well, and I think this pandemic has illustrated a couple of things to me anyway, and Stefan touched upon one of those things, is that when something arises, a health crisis arises, we often have to begin messaging almost immediately. And we have to have some kind of communications that provide information. We don't have the time early on to go gather data because people want to know what we're going to do, what we think about the situation, what our guidance and advice is. But we don't have a strong tradition in public health of having ongoing dialogue with communities. We don't have a strong tradition of doing research focus groups to understand how people perceive health recommendations, public health in between crises or campaigns. Whereas I think a lot of commercial marketers have consumer panels that they're constantly going to and trying to get a sense of, what's going on in that product category. How does my brand stand? What are people thinking? We don't do that in public health. We do it just in time research often, and then it's not really just in time. It's after we've already started communicating, and then we've got some time to do some research before we do the next bolus of communications. So I think that's one of the biggest challenges in terms of time is we don't really have good data at our fingertips, and we're not doing kind of ongoing pulse checking or understanding of what public health how people are perceiving public health actions and recommendations. The second part of that question that we asked the participants has to do with what are some of the challenges that you have found when it comes to using data, and I guess also what's your advice and guidance to overcome those challenges? So what are some of the challenges that you find typically come up, and what advice, recommendations, guidance would you give as to how to address those challenges? And I guess we'll start with Stefan. Would you like to start?
Happy to. Thank you for that. So I think a couple of challenges that come up regarding using data are, one, about how the data is languaged to communities, and also the relevance of the data. I think that's really important. If you collected data that wasn't relevant to the issues or the priorities of the community, then the relevance is going to be missing, particularly if it's not messaged well. And then also thinking, and we've talked about this already in earlier in the conversation, about how to language and how to message things appropriately, not using scientific terms. One of the strategies that we use at the University of Washington is called a community slide for researchers, because there's usually a lot of technical jargon in research. And so what are the key elements that communities really need to know and learn and think about, with respect to the research or with respect to program or public health program implementation, or even with communication. So I think being able to think about what those key areas are and being able to language and message those in lay language, I think are really important.
Good points. Anne?
The biggest challenge, at least for our data or any data that we collect, I think, is to be able to turn it out quickly and effectively to see any public health action. And, you stated that earlier, that I think as state leaders, we are expected to have, public health action to show effectiveness in a timely manner, especially now with, the pandemic going on and the vaccines. And so, we want action. Everyone wants to see action. So we, we conduct surveys, we conduct focus groups, and we want to have something out of it, an action. We have meetings, and you have action notes and everything. So I think that's difficult, and I think that showed in our surveys right now. We do things and we want to have actions, but I think a challenge, and I would pose to everyone, is that not to feel so limited, that if you have a group of people, and we use zip codes as well. I think Robert mentioned geomapping. We, for example, we have counties now that we know are not signing up for the vaccine as much. So I would challenge people to not give up on those groups who are not signing up, to go back out and to see what their concerns, their beliefs, their reasons are not, and to keep trying to educate people to make informed decisions. So those are challenges, I think, for everyone that they're facing, but to find out why they are not wanting to do it. I've never been one to force someone to take a medicine or a vaccine to make informed, educated decisions, but to continue to educate, find out what the concerns are, make it available. But I think those are, challenges anyone faces. We want to see quick action, but I don't think we should expect that from anyone with the way things have been rolling out. We need to give people time to accept it and do it on their own free will.
One way I think ways to communicate risk in a visual way. So, I can quote that the risk of serious reactions is 4 per million for the Moderna vaccine, and the risk of dying from coronavirus is 1 in 660, which is not even anywhere close. But unless that only helps if you're a numbers person. But if you make it a visual, the 4 per million versus the 1 in 660, it's obvious. And so sometimes finding different ways to communicate risk in a visual way rather than a numerical way. Finding routes of communication that we may not have used in public health in the past, like social media and bus ads and things like that, and figuring out where do people get their information, because it varies based on ethnicity and age group. I may be in a Facebook generation, but my kids, they don't look at Facebook at all. So how do you find out which groups and where do they get their information from? The other thing is, figuring out where people trust their information. And one of my frustrations is if you look at survey data, the people that people trust the most on vaccine is their primary care doctor, and that's where they want to get their vaccine. That's the one group that's almost been excluded from the vaccination strategy. So why aren't we using one of the most trusted folks? Why aren't they at the table too? And so, but again, back to where does everybody get their information? Let's make sure we're putting something there so we don't leave a vacuum in the wrong place.
Thanks. Robert?
Well, I think the challenge for communicators goes back to time. It's the time to gather data, time to analyze the data, evaluate the data, then implement what you found. And I think a lot of times, and I heard that term, we shouldn't reinvent the wheel. There are probably big organizations out there, big health departments, big organizations that have already evaluated the data. So that could save you some time if you could get your hands on that. So how do you do that? Well, associations, other national groups are just eager to get their data into the hands of those who want to use it. But I do think a key part for public health communicators is getting with organizations and partnering with organizations and joining associations and being part of webinars where this information is readily available. We're making connections, we're talking back and forth to people, we're networking, and we're leveraging the strengths of all of us. And I think this COVID-19 response has kind of forced us to do that. And I want to go back to one of the things that you talked about, Glenn, about we're not really good in public health regarding the collection of data, understanding data and interpreting it. I think that's changing though. I think we're being forced into that world, and that's a good thing because I believe it will make our lives a lot easier when we learn how to interpret it and use real-time data in a timely manner.
Thanks. And based on my experience, I think one of the things that I have often found is that if you get resources to do data collection, whether it's focus groups, in-depth interviews, or surveys, the people who gave you the funding often believe or assume that whatever you learn from that data will be immediately actionable and your communications will be pretty much effective and successful. And that's often not the case. And it's not the case because you didn't learn very helpful and important things. You probably did. But learning things and being able to do something about them primarily through communications are two different things. So I've done a lot of work in flu vaccination. I know from a lot of that research that people who are, say, 18 to 44 years old believe that influenza is a manageable illness for them. I mean, and they believe that based on their experiences. They haven't suffered serious flu. They haven't seen people suffer serious influenza. And so it's not a simple matter of telling them that their belief is wrong, that, whatever they've experienced isn't true. I think that's what makes it hard for us as communicators, even if you have good data about the barriers to people adopting a behavior. It doesn't necessarily mean you're going to be able to quickly or easily change their convictions, because oftentimes those convictions are fueled by their own personal experience or those convictions are fueled by their preferences. They prefer to do something, and they will still say to you, I agree with you, but I still want to do whatever it is that's putting them at risk. And you sometimes have to broaden the thinking of programs to get them to understand it's not only communications that we have to have in our toolkit. We have to consider, how do you provide incentives for people to do things? How do you make it easier for people to do things? How do you change the social norm? If the social norm currently isn't, most people are doing it. So I think those are some of the challenges that I think I have found in my experience when it comes to being able to use data, is that it's helpful to have, but it doesn't necessarily translate into immediately powerfully persuasive messages.
And I think, and I'd like to jump in here too, Glenn, I think data can sometimes be misleading. So if you are gathering data and you, for example, in the African-American community, you hear a lot about, I want more information. I need more information. Well, they probably have received more information about the COVID-19 vaccine than they've ever received about any other type of medical vaccine or intervention. So it might not be that they're asking for the data, even though the data show I want more information. They might not be asking for more information. They might be looking for proof. And that proof is making sure, just like you said, I've gone through flu and I know what a flu vaccine does, and I haven't seen people drop over. So I'm going to take a wait and see attitude on this COVID-19. It's not, you can give me all the information you want, but I'm not going to be the first in line to get the shot. So we have to be careful how we use data and what we think the data is telling us.
Very good point. There were some audience questions that were submitted prior to today, and one of them was, what type of data do you find is most important when breaking down or addressing barriers to vaccination? And does the type of data that you need to break down or address barriers to vaccination differ for different communities? And what's been your experience?
For me, I think I guess there's a couple things. For me, I would like to know where people are getting their information from, because I think that does make a difference. We find that at least younger people tend to get their information from social media. And then, of course, elderly people maybe get it from younger people unless they're socially, linked up. But and then also, I guess, there are concerns about safety. At least here in West Virginia, there was a lot of concern about the vaccine causing pregnancy issues or things like that. That's one example I'll say. So where do you get your information from? And then what are your safety concerns? I think at least are some of the information for data that we wanted to know so that we could address those with people for misinformation, I guess, so that we could push out proper information or education in the right way so that people are not getting misinformed. That's the kind of information we wanted.
Stefan, your thoughts on that question about what type of data is most important for breaking down or addressing barriers to vaccination, and does that type of data differ for different communities?
I think the data is somewhat similar. I mean, I know a lot of communities are having some of the same kinds of conversations, though there may be some nuances. And what's been helpful in my work is addressing the misinformation, addressing the FAQs sort of upfront, not sort of waiting for communities to have to bring it up, when I do talks and such, but to just sort of be transparent about what's happening, what we're seeing, to not sort of sugarcoat, the expected reactions from vaccinations, as an example. We know that people are going to have a reaction. So let's talk about it. Let's talk about what that looks like. And more specifically, let's talk about if there are any mitigating strategies that you can deploy to minimize the impact of these reactions on your life, right? So that you don't experience them severely. So I think getting ahead of this and being really transparent about it, I think is really important.
Bob, your thoughts?
Yeah, I'd say a couple things. I think still the one I want to know the most is what messages work for which populations. On the other hand, we notice that some messages work across populations. One would be the we argument, not the I argument. I'm not getting the vaccine for me. I'm getting the vaccine for everybody else around me that I care about. And so that sort of resets the thinking a little bit. I'm not getting this vaccine because I want to protect me. I want to protect my mom and my dad and my father-in-law, my neighbor who has diabetes, my friends whose son has a congenital heart problem. I'm not getting the vaccine for me. I'm literally getting the vaccine for them. And sometimes that changes people's focus a little bit and changes the sort of resistance. I think was said, acknowledging some of their deficiencies. When this first came out, phase 3 trial, that's 30, 40, 50,000 people. That's a lot, but it's not a lot. And so I heard a discussion where someone who was a vaccine person said he doesn't breathe a sigh of relief till we cross 3 million. Well, we crossed that. Now we're over 45, we're hitting 45 million-ish. Now we have the data. So I can understand the resistance back in, say, December, but now that we're February and we're 45 million, and now, and also explain to them that, we never experiment first on pregnant women and children. That's why we don't have data on pregnant women and children. But now that we know it's safe for everybody else, we kind of find out the pregnant women accidentally, because when you vaccinate 45 million women, people, lo and behold, some of them happen to be pregnant when they got the vaccine. I think we're somewhere around 15,000 pregnant women getting the vaccine now, so we can follow them and see. So I think acknowledging the data, saying here's the status of the data, so that people realize, no, this is a very structured analytic. We're doing all the things, we're checking all the boxes, and it's coming out. In the next couple of months, we'll have more data and it'll get better and better.
Robert?
My answer is going to be a little different, because I really do want to know what the answer to this is. And Dr. Wallace, you brought up you come out right away with the elephant in the room, what people don't want to talk about. And what I'm finding is, when you talk about the historical medical malpractices that have been inflicted upon, especially the African-American community and the Native American communities and others, there is some hesitance as far as from a communication standpoint that you bring that up, right? Because you're not wanting to reinforce the negative. So I've had conversations on whether or not we should talk about Henrietta Lacks and the Tuskegee, bringing that forward as opposed to talking about today, because we know what the inequities are that have been created because of those, past practices. And we don't want to reinforce it, but we also want to understand the concerns of people. So what would your your recommendation be on how to address that?
I think the context is so very important, Robert. And so thinking about and I want to reframe Tuskegee to the U.S. Public Health Service experiment at Tuskegee Institute. Because I think oftentimes in my conversation, saying Tuskegee marginalizes and it puts a burden on the historically Black institution unnecessarily. But, I think the context is really important. And so the idea isn't that we talk about these things just to sort of fan the flames, if you will, but it's really to help think about and to communicate and help communities think about it. The science isn't untrustworthy. There are unethical actors that have played a major role in the science. And this is the case, with every job industry, there are unethical actors there. We talk about the unarmed killing of Black people by law enforcement officers as an example, right? And that is, to me, how you help to also build and enhance trust in communities by taking the burden of this notion of trust off of communities and putting it where it should be, which is in the medical establishment and on researchers. That researchers and the medical establishment has to earn the trust of communities and be trustworthy in that regard. And I think, again, part of how you do that is to speak to these issues up front and be very direct about the impact that they've had in communities and the intersection of this work with medical racism, as been mentioned earlier, that these historical abuses are not the only sort of factor with respect to how people are approaching not just COVID-19 vaccines, but vaccines in general. And so what are the everyday experiences that communities of color are having when they engage medical providers? What are the biases that are at play? What are the sort of systemic racism and other structural factors that impede access, right? There are language issues there as well. Do the providers have the language capacity to engage in communities appropriately? So to me, this all really helps to wrap around trust and help to build and engender trust in communities. Hopefully that answered.
It did. Thank you.
Actually, can I ask a question of Robert and Stefan about that? Because there's even an element of atonement. And so maybe, is it worth, when we have these conversations, introduce the elephant and say, literally, the research training we have to go through now uses that history as the example of what not to do now. I mean, so it is at least recognized, and we literally are tested and quizzed upon it as an example. Is it worth bringing that up in a community conversation?
Dr. Wallace?
I honestly, I would say, Bob, that it is worth bringing it up, particularly if the audience is representative communities of color, Black communities in particularly, and, you're not a member of that community. Mm-hmm. I think it's absolutely worth bringing up. But again, I think context matters, right? How do you bring it up? And what is the point of bringing it up? Like, are you sort of making the connection to the historical issues and how that translates into, the disparities that communities of color face in terms of health in this country, and how we might be able to do something about it now, right? How can we work together, collectively to acknowledge, the issues that have happened before, to sort of do some degree of atonement for that, and acknowledge that the responsibility, again, of building that trust rests with the researchers and the medical establishment, but recognizing also that community plays a really critical role in that. So how can we work as partners in this process to build a better future?
Very good points. Question that listening to the panelists, given where we are today in COVID-19 vaccination, we're still very early in this, and there's a lot more vaccine hopefully to come. And I imagine we're going to find, as the supplies of COVID-19 vaccine greatly increase, there will be more attention focused on how many people are following the recommendation and accepting vaccination. So since this is a panel on using data to inform effective COVID-19 vaccine risk communications, given where you are and what you've seen, if you could recommend or make recommendations about what kind of research or data would we benefit from getting in the next couple months that you think would be really helpful in terms of informing COVID-19 vaccine communications efforts and messages? So if somebody said, we want to know what your recommendation would be. What are we missing? How would you respond? What would your recommendation be about the data that we should be gathering or trying to gather now that will help us in a few months from now when we have a greater supply of vaccine and probably more people hesitant to get it? Stefan, you want to take the first crack at that?
I'm sorry, I'm going to need you to repeat that.
Yeah, I guess my question basically boils down to what are we missing today that we would benefit from having in terms of a research study or data that would be really helpful for us in our efforts, say 2 months from now, when there's more vaccine, but as more vaccine becomes available, there's going to be clearly more people who are going to say thanks, but no, or I'm hesitant, I'm reluctant. Are there things that we could be doing in the next few months, research-wise, that would help us so that we end up with better communication strategies and messages 4 months from now when we need them? That make sense?
It does. Thank you. I think one of the amazing things that this opportunity provides us, and this conversation as well, is how to think about placing the COVID-19 pandemic, again, in the context of the overall health and wellness of communities that are disproportionately impacted by COVID-19, as well as other underlying health conditions. And I think this is a critical opportunity to do that sort of research work. If we're hyper-focused only on COVID-19, what happens with all the other health conditions in particular, and what happens with those health conditions when the next pandemic arrives, should that happen? And so thinking about interweaving these conversations, I know that we used to use words like syndemics, and I don't really hear that word much at this time, but really thinking about the intersection of these issues particularly when you overlay that with the work that's happening around health equity.
Thank you. Bob, what are your thoughts about what data, what information, what research should we be doing now to help us on the road?
I think it's the messages that would take someone from a vaccine hesitant to a yes. What really does work? I listened to a podcast recently with Adam Grant where a friend of him accused him of being a logic bully. And I think a lot of us from the science and PhD-ish, we tend to be logic bullies. We think we want the world to be as logical as we are sometimes. It just doesn't work. And so he talked about it was actually a discussion of a friend of him who was resistant to vaccines. And he said, what would convince you? And so I think whatever we can find out, what are those messages that really work? We know that do it for your family works, for example. What are some other ones? And some are general to all populations. Some are maybe more cultural specific. So yeah, I think the biggest research is what are the more effective communication strategies that convince a hesitant to a yes?
Robert, your thoughts about what we should be doing now on the data research front?
I agree. I think we have to continue to build the trust. We have some time, really, because the phases of this rollout of the vaccine, we started with the education phase, trying to let folks know that it's safe and it has a high efficacy rate. I think everybody has heard those messages now. So the next phase of this, we're really going to get, and the supply is not up with the demand. So really, we have some time to kind of really dig deep and find out what are really the reasons people are going to kind of slide into that hesitant mode. And I think, it's already been mentioned, how can we get you to yes? What do you really want to know? Is it really merely a wait and see attitude? And then how long is that wait and see going to take? You're going to need a year to know, or is it, as soon as your time, it's time for you to get the vaccine, would you be ready to go if we can, if it's proven to be safe and effective? So I just think we have a little bit of luxury of time, but not much. But we have to, reach out and do that hard work of getting to know what are the beliefs, what are the attitudes, what are the hesitations of our community members.
Anne?
I have two really quick that I'll say. I think we need socioeconomic determinants of health. I think environment does play a big part in, COVID-19, your environment, your housing, your education, your poverty level. I think all of those things determine, your transmission, accessibility, your decision for COVID-19 vaccination. Environment plays a big role. I think that can determine your whether or not you're hesitant for vaccine, your accessibility to it, your healthcare accessibility, especially in rural areas. Here in West Virginia, we have not a huge minority population per census data, but we have a very poor population state. So I think that's very important, at least speaking for West Virginia. And I also think we should start surveying children. We know Pfizer is starting to do studies for children ages. I think they're starting at 9 years old. So I think we need to find out through our adult population if they're going to want to vaccinate their children. If they're hesitant to vaccinate themselves, I worry about our children population coming up. So I would want to start looking at that now so we can start messaging for our children population. Sorry, my dog's making noises.
All very good answers. And I think one of the reasons I asked that question is as communicators, we have to have one foot in the present and one foot in the future and think about where things are going. And you've all highlighted things that we have to think about because they're going to arise, particularly as more vaccine becomes available and as recommendations are expanded, as access to vaccine is expanded, as we try to get higher acceptance and uptake among a wider variety of population groups. We need to be thinking about when and where and what do we need to be gathering now that can help us with our communication strategies, our community engagement strategies, our messaging strategies, even doctor-patient communication strategies. And so I think need to be mindful of that. My next question, I'll start with you, Anne. I'll give you a heads up. Based on your experiences to date, so now we'll use data, your experiences to date as the data. What communications advice what are 2 or 3 tips that you would give people about how to when it comes to doing more effective COVID-19 related vaccine communications? What communications advice based on your experiences and expertise and what you know?
I guess I would say that to be persistent but not annoying, to try to listen, to try to get as many people to the table in your state that has voices in your communities. Early on in our pandemic, we had a lot of stakeholders. We had our long-term care association, our hospital association. We had different groups at our table, our faith-based leaders, different people who had voices in their communities. Our health departments obviously are very engaged, but trusted community partners who are well voiced in their communities that help communicate effectively. So with those internal voices, they bring that forward to our level, and then we are able to message those out. So, communication is key across any type of agencies, across any messaging system, and then to utilize that and be able to pivot those voices and use that effectively, I think is very important. And I would say any feedback is important. Even a soccer mom's viewpoint in her community is important because she knows what is going on, and to utilize that, you never know how far that can go in a community. So I would say that's very important. You never know how effective a word choice can be. That would be my advice.
Very good advice. Robert, your thoughts on 2 or 3 things that you would give as advice for more effective COVID-19 vaccine communications, either plans or messages?
I would recommend, and this is a shameless plug, but we've had some success. I would recommend that public health communicators look at becoming a part of the National Public Health Information Coalition, because early on, we had our members, some of our members were out there really struggling with messaging. And lo and behold, maybe one state over, maybe across the country, we had a communicator that had already gone through that same issue. And there's a saying, nothing's new under the sun. Many times when you have an issue especially in communication, somebody else has already dealt with it or is dealing with it and may have an answer for you. It may not work in your community specifically, but with a little bit of tweaking, it could probably be helpful. So I would say if not NIFIC, join some other group of communicators that are doing the same things that you are. We have a repository of COVID-19 messaging that has been collected since day one that we started collecting and housing on our website. And it's always being updated. Glenn, I know you just recently received a bunch of information that we put out to our members to help them in their communication efforts. So I would say get connected into those resource-heavy organizations and utilize that information.
Yes, and I can tell you that it's a terrific resource, has links to all of the materials that are mentioned. And so you can actually get the original source documents, I think, which is tremendously helpful. Bob, your thoughts in terms of 2 or 3 pieces of advice to make COVID-19 vaccine communications more effective?
I guess adding to you talked about the present and the future, but I think we need to relearn some of our lessons we forgot about the past. So for example, in children, we've vaccinating children against rubella for decades, not so much to protect them, but protect the pregnant women that might be around them, their moms, their teachers, to prevent birth defects. And so we cross generations with vaccine recommendations, and Tdap's the other way, where we vaccinate now older people again with a pertussis booster to protect potential an infant from getting pertussis and dying from it. And so we have a long history of using vaccines to protect everybody else and across generations. And I think we've kind of forgotten that. And the same lessons will apply when we do coronavirus vaccination. We may be vaccinating these young children who have very little risk themselves, mainly to protect grandma, for example.
Brian?
Yeah, thanks for that. I almost feel like this could be a TED Talk just on this question by itself. But I think transparency is really important. We've talked quite a bit about that in this conversation. I also think that sharing information simply, and again, the goal here is not to persuade, but to inform communities, to make informed decisions. The other thing I will share is that we put together a suite of education materials. So talking about not reinventing the wheel. If there are materials that are already out there that are already from credible sources, please share those. And also, consider this an opportunity to develop the investment in communities, with respect to community engagement and meaningful partnerships with communities.
Thank you. Got time for two more questions. There's a lot of interest among the audience among vaccine safety and how best to communicate about adverse events, how best to talk about vaccine safety. So I'll turn to each of you and for your thoughts about vaccine safety communications and how to talk about reports of deaths after vaccine or adverse events related to vaccine. Any advice and guidance that you would give to our participants? Stefan, I'll start with you.
Thanks for that, Glenn. So I put the link into the chat and folks can access it. So part of the tools that are available includes an mRNA considerations document. As I mentioned before, it takes the FDA briefing documents and distills that information down into accessible language. And it includes information about the safety, what reactions were reported in the clinical trials, and provides some context there that may be really helpful and really in plain language to be able to communicate and say with communities. And I also think that it's important, as I mentioned before, to be upfront and transparent about this. The goal isn't to appear like we're hiding information from people, because that's going to simply perpetuate, longstanding myths about, the science, about scientists, about researchers. So communicate it plainly and be upfront about it.
Anne?
I agree. We have a toolkit out on our website that addresses all the main safety issues with COVID-19 vaccine. But, to be upfront, to address any concerns, if there is a COVID death, whether it's in the state or national news, we usually get asked questions, whether it's on our governor's briefing or with media questions. It's to answer that head on, address it, and even with patients who come to any vaccine site. But I think it's important to address those head on and to address patients' concerns. But I don't think there's any way else you can, avoid those things, because those are on people's minds. And I think the number one concern, especially when you hear a COVID-19 vaccine related death, and we have a pretty good system in place. When we have any adverse event, a major one, we are notified quickly so that we can also find out if there is something else related to that. But, transparency is key, especially during this pandemic.
Robert?
Well, I think if you don't, I agree with everything that's been said. You've got to be upfront and honest about any adverse effects or any deaths, and you've got to be timely with the information. You can't be seen as holding back information about a death or an adverse situation. And I think one of the things that helps you do is stay ahead of those who are intentionally putting out misinformation, because the misinformation mill started even before the vaccine was developed and distributed, that it was going to be safe, people are going to be dying, and that has not been the case. So I think if we can reinforce that message that over and over again, that the vaccine is safe and effective over and over again, but also be honest when something does go wrong, that you're the first one out there talking about it and explaining what happened.
I think it's worth pointing out that it's like the old saying, don't trust a chef who won't eat his own cooking. So the healthcare community did go first. The people who had the best idea of understanding the science and the risk, we all offered our own arms up first, and doctors and nurses across the country all got vaccinated. If there'd been a problem, we would have found out about it first. It's a good thing there wasn't a big problem, because you don't want to take out a lot of your doctors and nurses in a pandemic. But we all did go first. We know what the side effects are because we had them. I had the achiness the next day on the second shot and timed it on a Friday because I was off on a Saturday. Yeah, you may have to take a day off, especially after that second shot. But I think the fact that you can point to doctors, nurses, respiratory therapists, that we all went first. So we trusted enough. We knew the science. We trusted it and we did it. And I'm glad we did, actually. And so I think that's one way to kind of answer some of the hesitancy, is I believed it enough that I did it. So.
Good point.
I wanted to just say something about that because, this session is about data. And I remember when the safety numbers were coming out, or I'm sorry, the numbers of who were accepting of getting the vaccine, and the data came out that said that there was a large number of healthcare workers that were not interested in getting the vaccine. And when you dug, which worried a lot of people, but when you dug a lot deeper, you found that they were the direct healthcare workers, many of them who were low wage, minimum wage, direct care personal assistants that were lumped into the healthcare, and they had a reason to be hesitant about getting the vaccine. And so I think if you're able to explain to, making sure that people understand the safety at all levels, and especially when you're talking about healthcare workers, and you say, well, if they're not going to take it, I'm not going to take it, but explain that who these folks are and understand their situation.
Good point. So our final question, and I'll start this with Bob, is can you briefly talk about, what's the biggest lesson that you have learned in the past several months about using data to inform COVID-19 vaccine communications?
I'd say using it to double check your assumptions, because we all have our biases, and until you look at the data, sometimes you really don't know. And so it helps. Sometimes you're right and it confirms you, but sometimes you're wrong and it tells you that you're wrong. And so listen to it. Don't overgeneralize, because I think, what I said in Lincoln, our challenge is the diversity within our diversity, that every subpopulation thinks about it differently. And you really just got to go talk to them and figure out what it is. And that doesn't happen without conversations sometimes. And so you get a lot more in a conversation than you get with a survey instrument sometimes. And so I guess using your data and using your focus groups to re-examine your assumptions to make sure they're right or wrong.
Good points. And what have been your biggest lesson learned?
Sorry, that we can tailor some of our messaging to the data that we collected. And the biggest thing that we did get that WVU helped us with was their baseline information they collected, that we were able to know that mass clinic was not the word to use. And I think that helped us a lot in our initial rollout for the vaccine. But examples like that, so using data that we collected and putting that to work initially helped us. So I think getting information and trying to use it quickly helped, but I think now moving forward, using small focus groups and then knowing how we can use that on a state level is helping us. But we also know that we can't rush data either, because you need to interpret it, take the time to utilize it. So getting information, using it quickly, but at the same time taking a step back and knowing how we need to use that long-term goals, and for the long haul moving forward, we know we need to take those steps necessarily. So there's a lot of work to do there, but I think those things are helpful as well.
Robert?
Well, I think what I've learned is not to make assumptions about the data that you are looking at. I started off my talk talking about, 70% of Americans are accepting or eager to get vaccinated. But when you look at the data closer and look at how the question was asked, there were really only 40% of the people that said, I will absolutely go out and get the vaccine. 25% said that I probably would, 25% said I probably wouldn't, and 10% said I won't. So if you take the 40% that said they do and add it to the 25% that said I probably would, you've got 65%. Now you're happy and your job is done. But the reality is that's sometimes called, that 25% is sometimes called the polite answer on both ends, the probably not, probably will. So that's a 50% number there that you have an opportunity to change their behavior, change their attitude towards something. So understanding the data, understanding what it's really saying, and digging deep enough to really make it worth while to use and make it effective in your messaging.
Stefan?
Lessons learned, I think, are plenty, including pre-existing relationships and partnerships with community partners that have been longstanding are absolutely critical and have been absolutely vital to our success in this area. utilizing data that already exists and not recreating the wheel has been very helpful. And also understanding, and I guess I want to reaffirm that engaging communities and getting community level data takes time. So expect that, but the investment will be worth it.
We will finalize this or wrap this thing up by putting up a slide of some of the key takeaways. I don't know that. There we go. So to summarize some of the points that were made in the session, we heard increase the effectiveness and value of your messages about vaccines and vaccine implementation by building credibility and trust, understanding your audience, and incorporating information relevant to audience concerns. Another point that I think was made multiple times and is really important is you need to use insights gained from data to promote awareness and understanding about the risks of SARS-CoV-2 infection, the disease, COVID-19, the benefits of vaccination, transparency about safety monitoring, the timeline for the vaccine rollout, and the rationale for prioritization. In other words, a lot of the research has found that these are often among the topics that people are looking to learn more about, that they're interested in learning more about, and that we have to persuade them or convince them about. Another lesson learned is apply information and insights gained from community engagement to develop communication strategies tailored for specific audiences, create communications products in multiple languages, and tailor materials and messages to different health and science literacy levels. We didn't really talk about that explicitly, but I think it was a very common underlying theme of a lot of our advice that we heard today. Meaningfully engage with diverse communities online and through other means to develop and disseminate communications and to gather feedback about the effectiveness of the messages. And as Ann pointed out, it's also to gather feedback about the words and terms that we are using as part of our communication strategies and messages. And then cultivate relationships with trusted messengers from within populations of focus who can amplify messages to different audiences, both online and through other means, and provide input to the jurisdiction about community concerns. So I thank the panelists for their time and for their insights and expertise this afternoon. It's been a really terrific session. I know I have learned much, and I hope the people who attended have learned as much. So thank you very much, each of you, for taking the time out to share your thoughts and perspectives this afternoon.
Thank you, Glenn, for moderating, and thank you all.